All right, so we're going to get started with our first session. Now, why are we doing biliary atresia first? Yes, it is by far the most important topic in the world, but also Yama lives in Japan. So for that reason, we decided to be nice and let biliary atresia go first. And we do have Mark Davenport, who I'm assuming will be very polite and will not insult anybody. He'll keep no humor and very serious. And let's get going. So we have Dr. Alex Bondoc, Dr. Greg Tiao, Dr. Jorge Bezerra, Dr. Mark Davenport, and Dr. Yamataka, who are going to lead this discussion, and we're going to get into biliary atresia. So Alex, take it away.
Thanks, Todd. All right, wonderful. Well, thank you so much to Todd and the team for allowing me to participate with such an esteemed group of pediatric surgeons and a hepatologist who I know very well. But we wanted to share some information with you guys on biliary atresia. And so my first thanks is to Drs. Bezerra, Davenport, and Yamataka, who shared their slides very kindly. And I, with full disclosure, totally stole a bunch of Dr. Davenport's animations and a lot of their citations. So let's move forward. Let's see here. Okay, so you guys know this one all too well, not uncommon clinical problem. A full-term male infant who was former 39-week gestation, really normal prenatal course, nothing to really speak of. Postnatal course was relatively normal as well. Past meconium on day of life 1, is gaining weight appropriately at the well visit child checks. However, the patient started out a little bit jaundiced, remained jaundiced, and unfortunately now the stool is clay colored. So what next? Any questions here, guys?
So let's see. So we got about a month old and has remained jaundiced. So let's bring it out to, and I, by the way, let's see who we got on the audience. Does any of the faculty, while we're waiting, let's see, do we have no poll for this one, but what would people do? Just write it in the chat. Let's do that, Alex, since we don't have a poll for this one. Yeah, let's do what's your differential for now.
So really, this is just neonatal jaundice. Dr. Bezerra sees this fairly frequently, not infrequently, I should say. And so obviously we're talking about biliary atresia. And now some of the metabolic inherited disorders like alpha-1 antitrypsin deficiency, as well as Alagille syndrome. More perinatal issues, including the torch infections, another sort of esoteric inherited disorder, intrahepatic cholestasis, or PFIC, 1, 2, or 3, and then neonatal hepatitis is also on the differential. So, and so go ahead, Todd.
Alex or Georgie, what's the most common of these?
Yeah, it depends on where you are in the world. In the US and Europe, alpha-1 antitrypsin is the most common of them. But first, of course, the hepatologist needs to make sure there is no sepsis, especially urosepsis, right? Baby is doing well, except for what Alex talked about. Rule out alpha-1 antitrypsin deficiency. Make sure there's no sign of infection, especially viral infections, size of the spleen, and go for thinking about biliary atresia.
Georgie, so I don't want to be a scared parent. I mean, isn't neonatal jaundice normal? When do I start getting worried as a clinician or a parent that it's not normal neonatal jaundice?
Yes, especially at this age, right? It could be delayed physiologic clearance, breast milk jaundice, but think about the colic stool. So in the United States and Europe, by 2 weeks of age, if the baby still has jaundice, the pediatrician or whoever's in the patient needs to fractionate the bilirubin. If the direct or conjugated fraction is up, think about a pathologic jaundice.
Okay.
That's great. And we already have multiple people in the chat saying, fractionate that bilirubin, get those LFTs. They're already thinking ahead to the workup. So that's perfect.
That's awesome.
And as a segue, perfect timing. So here's a diagnostic algorithm Dr. Bezerra had shared with us, sort of from his practice and his partner's practice for the diagnosis of neonatal jaundice, as we sort of talked about. So again, fractionate the bilirubin, conjugated bilirubin. If you have unconjugated bilirubin, well, then we're walking down a completely different path. That's not what we're talking about here. And so the first thing is what we've already done is we take a good history and we perform the physical exam on the child. Oftentimes, you know, parents in this day and age will have photos of their kids' poop on their phones. But also remember too that the Taiwanese published in the Journal of Pediatrics, you know, I think in 2006, that they send all their kids home with stool color cards. And actually that's something we like to do after Kasai, because then parents have an easy reference to look at, well, what color stool can I tell them is a number, and what is it? It's concerning.
So Alex, I learned that from you. I think this team, last time we talked about this, in the audience, please answer, do you use stool cards at your institution? All right, keep going, sorry.
Sure, no problem. And so to the end of making those diagnoses that Dr. Bezerra mentioned, and I saw in the chat that a lot of people had already sort of brought these things up. What are we looking at? Well, we're going to check, you know, a fairly routine panel of blood tests, including a CBC to include those things at the top, LFTs, the PT and INR as a measure of synthetic function. Now here's where we're going to look at some other things like alpha-1 levels, or the phenotype, actually genetic testing, viral testing, including CMV, which I have later in the talk, and Dr. Davenport can elaborate on with his experience, as well as metabolic screens for inborn errors of metabolism, and then bile acid levels. So I guess with regards to laboratory values, I have just sort of to continue on this with the case presentation. So on, as we mentioned, total bilirubin level on day of life 4 was 10.9. And then in this hypothetical situation on day of life 36, the total bilirubin is now 11.6. But for our other colleagues, including Dr. Davenport, who had this in his talk originally, 198 micromolar per liter. But again, fractionating the bilirubin, the direct bilirubin is 9.2 milligrams per deciliter. So also quite elevated, 157 micromolar per liter. Other things of note that we kind of pay attention to is the alkaline phosphatase level is 318 units per liter, and the GGT is 596 units per liter. So question here for everybody is, would you like to check anything else?
All right, let's see, while we're waiting for the audience to answer. And by the way, I guess people are saying that there's an app, there's not only the cards, but the app. So maybe we can even find that link from the App Store and put it in there. Faculty, who on the faculty, anyone on the faculty can chime in here. Would you like to check anything else? And
For me,
go ahead, Georgie, or Yama, go ahead.
I think regarding laboratory values, I think this is for me enough.
Okay. Anyone else? All right, Georgie, you were going to say something?
Well, I just think it's always important to make sure that we continue to look at the baby, make sure that probably a glucose is available. You know, patients that can present like that with a low glucose, you think about endocrinologic disorder, midline defect. So just making sure that with little thing, we can make great progress and just look at the results.
Okay.
George.
Yes.
Could I have one question?
Yes.
I think other diseases except biliary atresia, do they have a hard liver? I think for me, examining the hardness of the liver extremely important to rule out.
That's
to diagnose biliary atresia.
That's the voice of experience. I completely agree. Good physical examination, put that finger there, feel how hard the liver is, always very helpful.
Dr. Kumar says abdominal ultrasound.
Oh, we'll get there.
He says we'll get there, Sati. Okay, let's keep going.
So the last thing is the last thing we've been using here in Cincinnati the last couple of years as a result of Dr. Bezerra's experience is what's called a matrix metalloproteinase level, or an MMP7 level. And so where this comes from is in 2017, Dr. Bezerra and his team did a large-scale proteomics analysis of about 30 children with biliary atresia, and identified MMP7 as a marker, a serum marker of epithelial injury and of biliary atresia. So what they did then is validate their findings in 2018 in 135 consecutive infants in China being worked up for intrahepatic cholestasis, and demonstrated that the predictive power of this assay, using a cutoff value of 52 or about 53 nanograms per ml, demonstrated a sensitivity of diagnosing biliary atresia of about 98%, with a specificity about 95%, and then a fairly high number needed to misdiagnose the disease. It's pretty high for MMP7, 25 needed to misdiagnose, whereas if you just looked at GGT alone, which some investigators have looked at it in the past, it's fairly low number for a misdiagnosis. So this is something, as I mentioned to you guys, we've been using. We have the capability through Jorge's lab to look at these serum levels at the time of diagnosis.
Jorge, do you want to comment a little bit more on where you think MMP7 is going in terms of impacting the whole approach to patients with biliary atresia?
Yeah, absolutely. Thank you, Greg. It's very interesting because we are always, I like when I see excitement that someone else discovered, because when we do it, and then it becomes biased. Having said that, even with a bench testing in the clinical side here, the specimens coming from the clinicians, we continue to be amazed by a high level of accuracy. It is very uncommon to have a baby with biliary atresia and a low MMP7. Now, interestingly enough, the cutoff values change depending. There are two other reports, at least, that came from Asia, I think one from Taiwan, one from China, and they both reported much lower cutoff levels. So there's something about the assay, how to handle the serum or plasma that is used, but it appears to have a very high predictive value for biliary atresia, with the potential, of course, to simplify this preliminary biochemical testing before we can get the surgeons involved.
George, how long does it take to get the result?
We run it here every other day. It's a 6-hour assay.
Only 6 hours?
Yes.
It's great.
I think the important thing here to recognize is this is still an evolution, but it may really change the diagnostic algorithm for patients with biliary atresia, where ultimately you may be able to eliminate a lot of other testing and eliminate things like a liver biopsy if we really grow confident in terms of its impact. So I think it has the potential to really alter the field in a dramatic fashion.
So once we've gotten, I've sort of reorganized my flow chart to show you guys what we have as far as our diagnostic algorithm after labs. Looking at the chat, lots of different suggestions for follow-up here with imaging. So I'll go to that next. And so as most people have already intimated, that this is probably the first imaging test any infant undergoes when they have intrahepatic cholestasis and abnormal LFTs. Oh, sorry, no sound. What did I do wrong? Can you guys still hear me?
Yeah.
Yes.
Oh, okay, sorry. So no, someone said there was no sound. Some institutions still do HIDA scans. Other things to consider would be MRCP, ERCP, but remember, in an infant might be technically challenging. And then just for fun, Dr. Bezerra included in this a historical interest in nasoduodenal string test. Any questions there?
Well, Alex, actually, there are some groups in Egypt, for example, that actually like to do that even nowadays. They do the
Okay.
string and they publish it, actually.
Gotcha. Okay. But realistically, as a lead into some information recently published by Dr. Yamataka, really the next moves are that traditionally have been liver biopsy, and I'll have some slides here in a second. And then obviously cholangiography would be what we would argue intraoperatively or at the time of surgery as the gold standard. But as we talked about, Dr. Yamataka published in JPS just last year his group's experience with using a combination of diagnostic laparoscopy with cholangiography in lieu of a percutaneous liver biopsy. And so what he presented there was that, as he mentioned sort of up front, as you heard him talking about, a combination of blood tests and laparoscopy can diagnose BA promptly and accurately. And so here we see what is BA, because not only is the morphologic appearance of the liver abnormal or consistent with BA, as well as the atretic gallbladder, and then his group is able to do the cholangiogram laparoscopically. And then that biopsy is unnecessary if you go straight to laparoscopy, where again, you can sort of visualize the liver and see the gallbladder, and then in the B panel there, demonstrate intrahepatic filling of the biliary tree. So I have one more slide on this, and I'll let Dr. Yamataka chime in. This is another study from Dr. Superina and Dr. Lemoine in Chicago, saying that the evolution of early liver biopsy may delay the diagnosis. So a similar contention, demonstrating that things that we know that we think to be pathognomonic for biliary atresia histologically, including bile duct proliferation, as well as portal edema, may not appear on very early biopsies and may delay Kasai. And they found in this case a delay of up to 30 days, which, as Dr. Davenport has published extensively on time or early surgery is associated with better outcomes, as well as younger age at time of surgery. And as I mentioned to you, that these two sort of pathognomonic findings were only seen in 1 of 6 cases and 0 of 6 cases initially. Sorry. Dr. Yamataka?
I think, can you hear me?
Yeah.
Because when we put the laparoscope into the intra-abdomen, I think instantly we can diagnose biliary atresia. Also before operation, in my experience, I think nearly all of the patients of biliary atresia has hard liver. I think hepatitis and Alagille syndrome, the liver is not hard compared to the biliary atresia. So I think in most of the cases, I think before laparoscopy, we can suspect the patient, whether or not the patient is biliary atresia or not. And then when we put the laparoscope into the abdomen, I think we can reconfirm the case is biliary atresia. And the liver is completely different even in the neonatal cases.
Yama, can I ask a question?
Yeah, Yama, the one population that I'm most wary of with that approach is the Alagille patients, because I think those patients do cross over a little bit closer to BA. Their livers sometimes can be enlarged and a little firm, not maybe as firm as a BA patient, but still a little bit subjective there. And then importantly, when you do the cholangiogram, it can be really difficult to differentiate. I mean, as you well know, if you do a Kasai on an Alagille patients, you just shorten that patient's liver, natural liver lifespan, and will convert those patients to needing transplant at a much earlier age. So that's really kind of the question I would have for you, which is,
yeah, I think
Alagille's population.
Yeah, I think you said a good point, because if you read our papers published in Journal of Pediatric Surgery, I think 16 cases was not typically of biliary atresia. Then we did the laparoscopy. All 16 were not biliary atresia, but we did the laparoscope, and 14 cases. No, sorry, 8 cases of Alagille syndrome, as you mentioned. So I think 16 cases may not need laparoscopic investigation, which is minimally invasive, but still invasive for Alagille syndrome. But the good thing is cholangiogram under laparoscope, and then we can see the patency of the intrahepatic bile duct and common bile duct. Extremely thin,
Yeah.
but we can see the patency.
Yeah, those really can be pretty thin and attenuated. It can be a tough call. I mean, to actually differentiate that on cholangiogram.
Yeah, very thin, but we also did liver scintigram.
Can I just pop in there a little bit?
Sure.
Go for it.
Yeah, the Bob Cowles and I from Yale wrote a letter in the JPS that's just been published on Yama's study, trying really to dissect the meaning of it, because it's a pretty radical notion, in fact, to give up a liver biopsy. And the key point about the biopsy is really to not go to theatre, to not have a general anaesthetic, and to not undergo an invasive investigation, and to exclude all those, I'll put it, medical conditions that sort of mimic biliary atresia. And there was a really high percentage of that in your series, Yama. So if you can avoid that, why not? What you're doing is really a prelude to carrying on with a Kasai operation. As far as the value of the Yama finger, I'm not sure that's got a great discriminatory effect, really. The Superina paper is certainly true. The liver is secondarily affected. We published quite a few years ago on infants that were coming to surgery for other matters who later turned out to have biliary atresia in the first week of life. They all had normal livers. So you can't really diagnose those early ones on liver biopsy. That's certainly true. You need to keep an open mind, I think, about the diagnosis if pale stools and jaundice don't resolve.
Mark,
so we're still at this moment sticking to a percutaneous liver biopsy.
Mark, thank you for your comment. But I think because of your center is very centralized and you have a very good pathologist, I think, very good at diagnosing the biliary atresia pathologically. But most of the centers, I think, I'm afraid a pathologist does not have a, good ability to diagnose biliary atresia only from their tiny liver biopsy specimen. That is my, one of the reply. And also, do you think, do you have a data, the liver biopsy shows the prognosis of biliary atresia or not?
What, liver histology?
Yes.
Yes, it's never really been shown. It's not that discriminatory, because what we look at is inflammation, inflammatory indices, and fibrosis, and they really haven't got a great discrimination in those babies that are coming to surgery before 100 days. We've looked at it a million times and not really found great discrimination.
And in UK, biliary atresia treatment is very centralized, only 3 places. Is that correct? 3 or
there's only
4?
3 centers for the entire.
So I think you have
UK
a very, I think, in the 3 centers, you have a very good pathologist to diagnose the biliary atresia. I think the situation is, very different from other countries.
I think if I can make a quick comment, both are great points of view. Oh, that's just one additional element for everyone to consider. As it relates to liver biopsy, I propose that there's an additional value, which is to quantify that inflammation and perhaps use that information to personalize the treatment. And we have a protocol that we're using that in Cincinnati to see how it actually helps improving the Kasai outcome.
Jorge, thank you for comment. I'm very interested in the prognosis and histology of the liver biopsy.
Okay.
Alex, are you there?
Yeah.
Let's move on. You've not got much time.
Let's do it. Okay. So I'll kind of go through this one fast. Here's a variant. Prenatal anatomy scan similarly at 36 weeks gestation. So this is what they see. Kind of keep that one in mind. Red as a double bubble, but the baby does not have polyhydramnios. Okay. And so the normal infant, as sort of previously mentioned, similar to our previous child at 40 weeks gestation, repeat ultrasound on day of life 1. A little bit more impressive, a lot more impressive. You can see the biliary tree there. No reading of real, oops, wow, okay, sorry. Way away, sorry guys. Technical difficulties as promised. So what next?
For me, liver scintigraphy.
Anybody
Yes, I think
else?
maybe a role of an MRCP in this particular case because you've detected a cyst. The key differential is between cystic biliary atresia and an actual choledochal. Those unobstructed choledocals can be diagnosed simply on liver biochemistry. Clearly, if the baby's not jaundiced, not going to raise conjugated bilirubin, then it's not cystic biliary atresia. And you could perhaps wait until you do to do the actual laparotomy for those.
Okay, and similarly, we would, for the sake of this this scenario, let's say the baby still has direct hyperbilirubinemia and clay-colored stools. As Dr. Davenport mentioned, we would probably MRCP the patient as well. And since this is a case from Dr. Davenport's experience, here are some of the images there. And then the recommendation at this point would be to proceed with a cholangiogram. And here's what you see. Large cyst containing mucus. And then as Dr. Davenport has elucidated here, it may not transmit as well, that they're intrahepatic ducts, but they're very irregular and don't look normal whatsoever. And so Dr. Davenport has published a couple papers here on the variant known as cystic biliary atresia, first in 2007 from his experience of finding 29 infants with this cystic variant out of 270 infants. What he found here was these patients get to surgery earlier. And then again in 2011, publishing the experience in both England and Wales. Again, similar findings that these babies, because of potentially their prenatal diagnosis and their follow-up, and our level of suspicion, which I think is one of the key points here, trying to differentiate between choledochal cyst and a cystic variant of biliary atresia, is that patients undergo surgery at a younger age, and he found that they do end up having a longer survival with their native liver, very significantly there, as you can see in the Kaplan-Meier. Okay, so we'll go back to just our biliary atresia diagnosis. And so you made the diagnosis. Now what? Easy, right? We've already been dancing around it. You operate, of course. And the obligatory photo of Dr. Kasai. And then the question becomes open or laparoscopic. These are two recent papers. The top one from Surgical Endoscopy in 2019 is a meta-analysis from a Chinese group, and then another paper from 8 centers in Japan, including Dr. Yamataka's, stating that that laparoscopy, when taken together, that they demonstrate faster jaundice clearance rates, decreased intraoperative blood loss, which can be very important as a marker of complexity of surgery for future transplantation, quicker resumption of PO intake, and a shorter duration of analgesic use. The meta-analysis almost all did demonstrate a statistically significant difference in increased operative time for the laparoscopic case, the laparoscopic Kasai, interestingly enough, only 40 minutes. And then of note that in the Japanese study, there was a much higher revision rate in laparoscopic Kasai to the tune of about 33%. Of those cases had to go back to revision, whereas in the open cases, only about 5% underwent revision. So as a side question, in the setting of cystic biliary atresia, Greg wanted to propose, where would you anastomose your Roux and Y limb to do the portoenterostomy? Would you do it at the hilar plate like traditionally, or would you do it to the cyst wall? Strong feelings, Dr. Davenport or Dr. Yamataka?
Can I say, I think it depends on the size of the common bile duct in the portal plate. If the size is less than 5 millimeter, I think we can diagnose. If the diameter of the common hepatic duct in the portal plate is more than 5 millimeter, we can common hepatic
Use the cyst.
duodenostomy.
Okay.
Yeah, cyst, to the cyst. But
Okay.
if the ductal, the hole is very tiny, I think we have to do Kasai portoenterostomy.
Yeah, so most of them, they're type 3. So there really isn't a major duct. And so we almost invariably do a Kasai type operation.
Gotcha.
Now, historically, obviously, other people didn't do that. And if you have got a genuinely large connection with the intrahepatic biliary tree, then bile will flow, the jaundice will recede, and they have done well, but some clearly don't. And we do what we would normally do for a regular, straightforward, isolated biliary atresia, really.
Mark?
For these
Mark?
cystic ones.
Mark?
Yep.
Have you seen the type 1 cystic biliary atresia and the common hepatic duct is more than 5 millimeter?
So some do have, the ones obviously with bile in them, there has to be a connection. And your cholangiogram should sort out the degree of dilatation, if there is any, in the intrahepatic ducts. Remember, none of these really have dilated intrahepatic ducts because that's not the natural history of biliary atresia.
But I think that those cases are very, I think, rare.
Yeah, I think, and that's actually kind of the reason I was, I asked this question, which was, I think there are variations, and of course, cystic BA is the less frequent of the diagnoses that we see. But Mark, I thought that was very interesting in your paper, where you really strongly encourage people to do more of a Kasai portoenterostomy than perhaps was traditionally thought of as a cyst enterostomy, a cyst anastomosis. Because, and we actually transitioned more to that with our more recent cases of cystic BA, where if we really saw minimal or very attenuated biliary ducts extending radicals extending into the liver, we've gone to a Kasai. Whereas in the past, we might have used a cyst wall. You know, we did a study that was done here by one of our pathologists, looked at the cyst wall of these patients, of the patient population that we saw, and none of them had epithelium. So the challenge, of course, is if you're doing a Roux to a fibrous, a cyst wall, the likelihood of that being durably patent strikes me as unlikely. And that's wherein we kind of agreed with your thought process of transitioning really to the hilar plate.
Can you hear me, Greg?
Yeah, yeah.
So when you decided the anastomosis, did you do the intraoperative histology examination?
Yeah, these patients oftentimes already had a liver biopsy done pre-op. So we had
intraoperative common bile duct, intraoperative histology of the cyst.
Yeah, that's actually something that we talk about, which is we'll get a frozen on the cyst wall, especially in those patients in which you're leaning more towards a choledochal cyst. Because I think a choledochal cyst, you'll have biliary epithelium lining the wall, whereas I think in a cystic BA patient, they won't see that. And I think that is something that you can delineate on a frozen. I think anything more complex, I think would be difficult. And so that's where we will consider a frozen section of the cyst wall. But after reviewing Mark's paper a little more closely and seeing that his recommendation was to go to the hilar plate, and we had a case where we did a cyst wall anastomosis and the patient ended up being transplanted like 3 months later. It kind of helped us lean more towards the way Mark was thinking about it.
Moving forward a little bit, something a little more recent as an adjunct too, something to consider that's because of its sort of benign nature as a fluorophore is indocyanine green, which is used quite a bit in adult surgery, but not as much in pediatric surgery. But using this as an adjunct to demonstrate whether or not your hilar plate is adequately transected, and if you can delineate these biliary radicals. So the first paper is from 2015, which was a feasibility study where they looked at the fibrous cone to see if they could tell if there was still patent biliary radicals. The more recent paper on your right came from JPS at the end of last year, and it actually allowed the surgeons to use indocyanine green to make sure they were cutting at the right place. because they did see areas where there was no fluorescence, so they cut into the plate a little bit further and were able to demonstrate fluorescence and correlate it histopathologically. And so we've used it a couple times on our Kasais. And so what you see on your left is the normal sort of laparoscopic view you would see. But then as you go to fluorescence, it's obviously very green because of the degree of biliary stasis in the liver. But what you can see is the more intense areas, they're correlating with what seems to be patent biliary radicals. And luckily, this patient did drain and has continued to drain for the last 6 months. Another question Greg brought up was, when should I revise my Kasai, or should I ever revise my Kasai? We did publish a paper in Annals a few years ago, and there's been a lot of data from the Japanese groups about consider revising your Kasai after you've normalized less than 2 milligrams per deciliter of total bilirubin, and if you go up after that, as well as recurrent episodes of cholangitis, a persistently elevated bilirubin after Kasai, which has been sort of controversial amongst our group, when it's been requested or request for evaluations, and then a failed response to a gallbladder Kasai, which we haven't really done in the recent past. Well, here, what are my adjuvant medical options? You've done your Kasai, hopefully you're draining, but if not, what are your options? So sort of more simplistic, or at least low risk, quote unquote, medical therapies would be ursodiol, which is a nice choloretic to use that we keep our patients on postoperatively. You can always consider antibiotics. We do prophylax our patients, and I'd be interested to hear Dr. Davenport and Dr. Yamataka's sort of protocolized approach if they have one. I suspect they do. Nutritional optimization is obviously big, and then two things we're going to focus on here in a couple slides from Dr. Davenport's group is anti-cytomegaloviral therapy when it's appropriate, as well as steroids.
No, so Dr. Rahman asked a question in the chat group that is something that I've thought about a lot, and that's doing a Porto-Dudenostomy instead of a Roux. And I was wondering if any of our panelists who have way more experience have ever attempted that or thought about it, or what their thoughts are on that. I think it's a great question.
So the hepatoduodenostomy, did I get?
Yeah.
Yes.
Yeah. Okay, so I did it twice actually, but not, one was to the stomach and one was to the duodenum. But the only reason I did that was simply because both children had short gut, so they didn't have gut available for a Roux loop.
Yeah, and we've dealt with that once before, where we ended up using the appendix as our conduit. Mark, we would not consider that, but we're also a transplant center, so yeah, us generating a Roux just actually saves us time when we're actually doing the transplant. So the likelihood of us
how many actually work, you know?
Yeah.
These next two slides from Dr. Davenport, I think, are really important to keep in mind as adjuvants to your Kasai if you're not draining or the stool isn't perfect. Certainly, so the first with regards to anti-cytomegalo-therapy, Dr. Davenport published this just in 2019 of his experience of patients who were IgM positive for CMV at the time of diagnosis, all of which had type 3 cystic BA. 28% were sort of what he called his standard group of BA patients, and then 8 patients underwent anti-cytomegaloviral therapy, and published some pretty striking differences, clearance of jaundice, that the patients who were treated for their cytomegalovirus had much higher rates of jaundice clearance, as well as those who avoided transplantation, i.e. meaning they survived for longer periods, meaning the sort of cutoff point here was 2 years, surviving with their native liver at 2 years. And you can see that the viral therapy patients, almost 80% of those patients had their native livers at 2 years after Kasai.
So there's clearly a controversial area, there's no doubt about that, but in 10% of our infants, we demonstrated they were CMV IgM positive. And when we looked back then their history post-Kasai, they had a dreadful outcome, dreadful. Less than 10% were clearing their jaundice in our first paper. So we rationalized it and said, well, CMV can be treated, and you transplant boys do it all the time. So let's do that as well, in addition to the Kasai. And this is the sort of experience that we published last year. Now, in retrospect, we're now trying to refine it a little bit by looking at the quantification of the actual virus itself, because clearly IgM positive is simply a yes or no. And the actual quantification of the viral load may actually indicate whether we need to actually administer antiviral therapy. But it's all up for discussion, clearly.
Mark, how long do you treat for?
Well, as you know, because you've met our 10 hepatologists that we have at King's, so there's 10 different opinions as to what we use, how long we use it, etc., etc. But again, they were using quantification. So when the viral load went down, they stopped it.
Yeah.
Now we're using oral valganciclovir. So that the decision to embark on treatment is not so much of an issue as IV ganciclovir.
So I would say maybe another minute or so, and then what we're going to do is go to the next session. Yeah.
Okay, sorry. I'll do steroids quick, and then Dr. Davenport's summary slide here. Obviously, steroids have always been a hot topic with biliary atresia postoperatively, and so this was a meta-analysis that Dr. Davenport cited in 2015, demonstrating that not only is age at the time of Kasai a sort of covariate that's important to consider, but that steroid therapy does improve jaundice clearance. And so at least for our part, depending on what that histological appearance and the age of the child is, we have been sort of taking that personalized approach that Dr. Bezerra mentioned as to whether or not the patients would qualify for steroid therapy. And so I can send out this revised algorithm based on what we've talked about with Dr. Yamataka and Dr. Davenport and Dr. Bezerra of sort of how we've been thinking about things, sort of as a jumping off point from the previous algorithm for diagnosis of biliary atresia from before. And then this very, very, very nice conclusion summary slide from Dr. Davenport is, so early diagnosis is key. It's been demonstrated multiple times that patients who come to Kasai earlier do better. Surgery, we talked about open versus laparoscopy. We didn't really cover whether you exteriorize the liver or how extensive your dissection of the hilar plate are. And then know your results. What are our results? Well, it's kind of twofold, as you've seen in the studies I've cited, or that Dr. Davenport and Dr. Yamataka and Dr. Bezerra cited, that clearance of jaundice is one, and native liver survival or prevention of transplantation. And then potential for change, as we sort of blasted through there in the last 5 or 6 minutes. These are all things that you can kind of think about once your Kasai is completed, but can you salvage your Kasai if you don't have drainage, or you have sort of insufficient drainage, and that still really gives you a sense of how good your bile flow is.
So, okay, a few things here. Number one, this was awesome. This last summary. Mark, you actually did good work. I didn't know that was so a great summary there. We're going to crop that little video session, and we're going to post that out for people later on. I think people love having the nuts and bolts summarized. We'll push this whole thing out, but even that, Rod and the students can do a great job of pushing that out through social media too, these high yield points. And nobody even noticed, but Andrew Christensen, our developer, actually just upgraded our servers with no glitch. So it works perfectly now. We've got much higher speeds and capacities, so you'll notice the difference. So you don't have to refresh unless there's a problem. I want to ask all of you, please go to the chat. There's been a lot of comments and questions that we didn't get to because we're running out of time, but please address them. Make sure people's questions are answered, and feel free to email us any comments or questions. I'm tponsky@gmail.com or whatever you want, and we'll answer them. So actually, Alex, anyone want to make a final comment summary that you want to get out there before we end this? No? Are we good? Okay. All right. Fantastic. That was an awesome summary. You guys are the power team.